So welcome back. We're about to begin the breast cancer experience here at the National Summit. We'll be finishing out with 2 modules today on triple negative disease, HER2 positive, and then first thing in the morning we'll start out with a double module on ER positive disease. A lot to talk about as always with breast cancer. We have a great faculty to start out here talking about triple negative disease, Dr. Adam Brufsky from the UPMC Hillman Cancer Center in Pittsburgh, Pennsylvania, and Dr. Kevin Kalinsky from the Winship Cancer Institute at Emory University in Atlanta. Also, welcome back to Vic. It seems like a long time since I saw you early this morning, Vic Malhotra from Spring Hill, Florida, here to help me out pumping the faculty with questions. So before we kind of get into the data, I just want to take a breath and Adam, I ran into a bunch of fellows here, came up and said hi, and I was just thinking, I always think about people new to oncology and, trying to figure out what's going on and not realizing where we've been. Maybe you could just kind of put in perspective from your point of view what some of the biggest advances have been in triple-negative breast cancer, a lot of which we're going to talk about today over the last couple of years.
Yeah, I mean, it's really interesting, and I think that what we're going to see, and we're going to talk about this a little bit more in the discussion, is that, what we're finding even in our clinical trials now is that a lot more people are de novo, and we're doing such an incredible job with early stage disease that we never used to. I mean, I think immunotherapy has been a huge advance. I think PARP inhibitors that we're going to hear about have been a huge advance. I think the ADCs that we're going to hear about really have been major advances. And I think that bringing all of these from the metastatic disease, which all seem to actually have decent activity, into the adjuvant setting, fewer and fewer people now are really relapsing with triple-negative disease. And I think that our hope is it's going to become like HER2-positive disease, where the vast majority of people in clinical trials are de novo right now.
Kevin, anything you want to add to that? I was kind of thinking the original premise of ADCs was that, basically the hope it was going to be more effective than chemotherapy. And we're starting to see that, particularly in breast cancer, but even outside of breast cancer trials. For example, we're going to talk about in the first-line setting, comparing chemotherapy with IO to ADCs plus IO. Any thoughts about why? Do you think this is basically the premise of ADCs being realized?
Yeah, I do. And I mean, just to even continue what the GU conversation was, I think the ADCs that we have now, they are effective drugs. And I think if we're going to be forward thinking, we'll see whether they have a role in the early stage space, like in this residual disease space. And I also, we'll touch upon this a little bit just in terms of the next generation of ADCs, new targets, new payloads, because I think that that's where we really need to go to overcome some of the resistance that we're seeing.
And Vic, any initial questions out there? Again, I'm curious what it's been like for you seeing the ADCs sort of come in. I think maybe initially we were thinking they weren't going to have any toxicity, and then we started to see there was. Any sort of questions to the faculty, any observations?
Yeah, absolutely. So I think, of course, the Keynote 522 has been a game changer. I agree with Dr. Brufsky's comment that the last probably 10 triple negatives I've treated, thank God, they've done amazing. PCRs for most of them. My one question is, I do have a very elderly population, so we were just discussing, at what point do you feel compelled if somebody has come in with a stage 1, 1.7 centimeter lymph node negative, 85-year-old, relatively healthy but frail. At what point do you decide to do adjuvant versus not, and what would you pick?
Kevin, any thoughts on that?
Yeah, I mean, it does depend on the patient and comorbidities and things like this. I mean, for triple-negative breast cancer, we see that those recurrences can be within the first 5 years. And so the question is, what does that patient's life expectancy, what might that look like? But if it's because we also know some people are age 80 and they're very robust, and then others are frail. And so for those who are really frail, then sometimes we will just watch. But for those for whom we feel compelled to do some therapy, I also sometimes use agents like CMF, when I have a patient, when I feel like I need to do something, I don't really want to do something, but I feel compelled and we agree in the patient conversation to do something. Sometimes I keep that in my back pocket.
So, I think we're going to see more data and ASCO follow-up from 522 presented, I guess long-term follow-up. Also interesting to think about, Adam, I was working with Lars Pozdai from Yale recently, and he did a study looking at SEER data. It's interesting. that almost a quarter of breast cancer deaths are from people who start out with stage 1 disease.
Yeah.
So I think that might be an area that maybe we could do better on in the future. But let's get into this in terms of specifically what's going on in triple-negative disease. And, of course, one of the biggest stories, particularly over the past year, has been TROP2 ADCs. So, Adam, let's hear what happened.
Sure. So let me kind of go through this. These are my disclosures. So again, I think we've kind of heard this from other tumor types already. I think that the whole idea behind the ADC is to actually deliver a chemo payload to a specific a target that's been targeted by a specific antigen on the cell surface. And the whole idea is that it binds to the antigen, it's internalized, the antibody is dissolved in the lysosome, and it releases the payload. But, it's a little bit more complicated than that. And I think that, there are a lot of things that are going on here. You have an antibody, you have a payload, and you have a linker. And, how the three interact with them, the distribution of the antigen on normal versus tumor tissues, it's extremely complex. The microenvironments where the linkers are cleaved are very complex. And this is why, it was a simplistic idea. Let's just put a chemo onto an antibody and give it to people. But it turns out to be incredibly complicated. Now, the sacituzumab actually was the first TROP2 ADC. And again, looking at sacituzumab, you may have heard it. I don't know if you've heard it because I wasn't here for the other talks. But generally, sacituzumab is against TROP2. It's a trophoblastic antigen present on about 96% of triple-negative breast cancer, about 80% of ER-positive breast cancer. And it turns out that it has this linker on it, CL2, that is dissolved, that breaks in areas of low pH. So if you have a very rapidly proliferating tumor and a very acidic microenvironment, it will actually cleave in the microenvironment and release the payload, and that's a bystander effect. It has SN38 as its linker, which is a derivative of irinotecan, and it's not as powerful, I think, as deruxtecan, as we're going to talk about in a few minutes. But that's the idea behind it. Again, there's a lot of data that we developed, that has been developed by a lot of people over the last probably 10 years using sacituzumab in second line and beyond triple-negative breast cancer. And obviously, we try to bring these drugs to the first line. And so ASCENT-3 was actually, I think this one was presented, ASCENT-3 was presented at ESMO, ASCENT-4 was presented at ASCO last year. But in ASCENT-3, again, these were patients who were generally CPS negative, so they were PD-1L1 negative, or they were PD-1L1 positive with CPS greater than 10, but for whatever reason couldn't get immunotherapy, for whatever reason, either rheumatoid arthritis or some autoimmune disease. And they were randomized, a decent number, about 550, were randomized to sacituzumab day 1, day 8 versus physician's choice of chemo, the typical chemos we give, paclitaxel or gemcarbo. And again, the primary endpoints were PFS. The nice thing about this trial in particular is that it allowed crossover, that if you crossed over, if you were in the control arm and you crossed over, you were allowed to get sacituzumab, and 81% of the patients who crossed over got sacituzumab. So that's a really nice design. Hat off to Gilead for doing it this way, spending the money, because sacituzumab in some parts of the world is not available as second-line therapy. Anyway, just to kind of briefly go over the data, there was an advantage, a survival advantage here, a PFS advantage of about 3 months, a hazard ratio of 0.62 that was statistically significant. I think you can clearly the curve separate by month 6, and they continue to be separated out at about 24 months. So you are affecting probably about a quarter of the patients are actually having some response to this that is durable. Other things, the other big trial, again, that was announced, this is at ASCO last year, was ASCENT-04. Same design, except this trial actually took patients who had a PD-1 CPS score greater than 10. And again, randomized them to sacituzumab and pembro at typical doses, or chemos, which usually were paclitaxel, nab-paclitaxel, or gemcarbo, with pembro in both arms. And again, the primary endpoint was progression-free survival. And we see the same story by and large, the same hazard ratio, 0.65, a little bit better in terms of absolute numbers, 11.2 months in the sacituzumab arm versus the 7.8 months from the chemo arm. Overall survival in these trials, not surprisingly, this looking at ASCENT-04 overall survival, is unchanged. And that's not a surprise because we know that sacituzumab has a survival advantage in the second line and beyond in triple-negative breast cancer. So if 81% of the patients that make it are crossing over, you don't expect to see a survival advantage because that's kind of diluted.
So before you go on, Kevin, any comments on sort of about life on sacituzumab in terms of tolerability, complications, toxicity, preemptive growth factors, quality of life?
So sacituzumab govitecan is given intravenously, 2 weeks on, 1 week off. The things that I talk about with patients, everybody loses their hair. Well, that's my experience. Though in the trials, it suggests that alopecia is lower. Everybody loses their hair. Talk about growth factor use. If you look in the studies, including real-world studies, 25 to 50% of patients are receiving growth factors with SG. And then also some patients have diarrhea that can be managed symptomatically. Like if you really need to escalate, atropine may be helpful for patients, but trying to use other anti-motility agents before that. And fatigue is the other side effect, I would say. And to me, the only way to help that particular side effect is dose modification.
Vic, any questions?
Yeah, I mean, so we are all very familiar with SG. The question is, in community, we hear anecdotally people using it every 2 weeks. Do you folks have any concerns about that? Is there any data on it? And I traditionally have done day 1, day 8 with a growth factor day 9, and that's worked out pretty well.
Yeah, I use growth factor. The same thing. It's day 1, day with growth factor, long-acting GCSF day 9. But I'll tell you, in our community in Western Pennsylvania, and going in almost all the way to the Philly area now, people are using it day 1, day 15. I don't think there's any data yet. I think we're going to have data. I think there's a phase 2 somewhere that someone's going to see, and we could probably get enough data from the real world to compare it to it at some point, I'm guessing.
Yeah, that prospective study is ongoing.
Yeah.
So, Kevin, when we saw the data last year at ASCO, when Sarah Tolani presented it, did you basically change your practice at that point? And have you been using it since then? And how do you deal with patients? I imagine quite a few of these people had prior 522 and prior IO.
Yeah, I mean, one of the issues with as more and more data come out, and then trying to contextualize what's going on, in the Ascento 4 study, only about 6 patients had prior IO, and so it's a little bit of a data-free zone, and so I don't know that we know exactly that best time point. I mean, I would say if I have a patient who's progressing on their adjuvant Pembro, I'm a little concerned about continuing Pembro and adding SG. But certainly if somebody had completed their adjuvant therapy more than 12 months, sometimes if it's more than 6 months, I would consider it, but certainly not while patients are on it.
Vic, do you also flip over to SG plus Pembro after last summer?
Yes, absolutely.
So let's continue on. I was going to ask you, do you think the Steelers now have a new quarterback?
We'll see. Although they really got burnt by the Eagles. I'm not going to get me started on that. Everybody watched the draft 2 nights ago. We'll know what happened. Anyway, all right. So back to science, not football. So the bottom line is that we actually now have we've had for quite a while, another ADC with a slightly different design. It's datopotamab deruxtecan. And this, again, is a TROP2 antibody, different antibody because it's a different pharmaceutical company that made it, but it's also to TROP2. It has a different linker, this cleavable tetrapeptide linker. It's not really it's more of a chemical, it's more of a protease cleavage. And basically, it's bound to deruxtecan. And deruxtecan is an exatecan derivative that's probably one of the more powerful ones that we have. And so it's a little bit different, and actually it's what the baseline is, and I think we're doing the HER2, I think, next here. You'll hear about trastuzumab deruxtecan, but it's basically the same payload. And so we really felt that because this had a better payload, this is going to be a better drug than SG. And we'll see if that's really true or not in a minute. So this is the TROPION-Breast02 trial. This trial took also patients who were first-line triple negative, no prior chemotherapy, and they didn't have a median, what we didn't talk about before. You had to have at least 6 months disease-free interval to go on to the ASCENT studies. In TROPION-Breast02, it could be any time. And so they got Dato-DXd, which is given Q3 weeks, versus the investigator's choice of chemo, which is a little bit stranger. It's not a little bit different kind of chemo. They allowed paclitaxel, nab-paclitaxel, CAPE, eribulin, or carboplatin as a single agent. And so that was kind of the design. It was a dual primary endpoint study. This is why it took a long time, longer than we all expected, for this trial to announce, because they had to get the OS endpoint. They had the PFS endpoint because it was a dual endpoint. They had to do both at the same time. for it to announce. And this just shows you the first-line metastatic disease, that clearly the same thing. You got a hazard ratio of 0.57. In absolute terms, there's a difference of about probably 4.5, 5 months, 5.6 months to 10.8. In this, there was an overall survival benefit in this trial, and in this trial, crossover was not allowed. And it wasn't because I think AZ and Daiichi didn't want to do the crossover, it's because it wasn't a standard of care. And so I think the FDA, most likely when they had the discussions, probably said, look, you can't really do crossover because it's not a standard of care. You could offer it, but then you're doing a completely different kind of study. So, and you're really looking at two different indications for the drug. And I kind of understand this. They've taken a lot of criticism for this, but I kind of get why it had to be this way. But nonetheless, there was no crossover. It was a survival advantage here of about 5 months with a hazard ratio of about 0.79. It was statistically significant.
So again, we'll come back to Kevin. Life on Dato is a little bit different toxicity profile. Particularly interested about your experiences with mucositis.
Right. So as Adam had mentioned, different administration. It's given once every 3 weeks. The main thing that I would like to stress is just the stomatitis. It's really important to utilize prophylactic rinses like the steroid rinse. In the adjuvant residual disease study, TROPION-Breast03, which is not read out yet, it wasn't mandatory. And I will say, with my community colleagues, I had seen some patients who had very significant stomatitis. And so really, I would strongly encourage you to utilize the prophylactic mouth rinse as opposed to SG. Not everybody loses their hair with Dato. And then the other thing is just the potential keratitis. And so it's recommended that patients not wear contacts while they're receiving Dato. And the other thing that might help in terms of when patients are getting their infusions is eating ice chips in terms of the stomatitis.
So as mentioned, we did this program a couple weeks ago in Puerto Rico with SGO. Brad Monk was in it talking about ADCs. They brought up something I never heard from you all. Have you heard about this ice device?
Yes.
It's like a device in your mouth. Have you seen this?
Yeah, we just started using it in addition to the Dex rinse, which is standard for everybody. I have 2 patients on Dato. We just rolled it out. Looks and it's easy to use. They're actually giving it out to the patients with no cost or very little cost. So we are very excited about it.
May I ask what that is?
Yeah, I know. I never heard of it either.
Essentially, it's a device that they will refrigerate, has some coolant in, which freezes, and then each one lasts for an hour or 2, and then they will, or maybe even less, but then they can replace it. The multiple in a pack that come in that use that.
Instead of ice chips, kind of the same.
Yeah, it's like ice chip, but it's just more
kind of
neat.
Form to your mouth a little bit more?
Yeah, you put,
You hold it.
chemo mouthpiece.
Chemo mouthpiece. Okay, interesting.
Anyhow, so let's get back to which one you might want. If you had access to both Dato as well as sacituzumab, what's first line in your book, Adam?
I'm just more used to SG. I think it's just a more familiarity. I've started to use a lot more Dato now, actually, and I'm really kind of very pleased with what I'm seeing, to be honest with you. I think that my one fear with Dato, even though the ILD rate is 3%, no one wants to be that person with ILD in the ICU on a ventilator. And even 3% for me is I just don't like ILD. I just don't. And no one does. But it's thankfully very, very uncommon with Dato. I have not seen a Dato ILD yet. But I have had success with it. I think I'm kind of liking it. I'll use both, but I've used SG just because I was familiar with it more than anything.
So also hear about ocular issues, but I'm not sure that's much of an issue with Dato. Kevin, is it?
The recommendation is not to be wearing contacts. Right. I would say that we're not preventatively sending patients to ophthalmologists, but for sure if there are symptoms that are developing at that point.
So just like in SGO, here we go. Another ADC, SAC-TMT, another TROP2 ADC.
So again, SOC-TMT is kind of interesting in that, again, we're just kind of like feeling our way around this. And I think that SOC-TMT has a different linker, this K-thiol linker, that it's a little bit more stable. It has a different kind of topo 1 inhibitor, this belotecan inhibitor. So you're kind of tweaking the ADC to see if you can actually overcome, the toxicity, maybe get a little bit more efficacy. But again, it's a TROP2 ADC with a different linker and different payload, roughly the same drug-to-antibody ratio of about 7 to 4 to 1, which sacituzumab has. So this is the Optitop Breast 01 study, and these are patients. Again, this is very similar to the ASCENT trial. It's kind of that was done with sacituzumab. It's a patient with locally recurrent or metastatic disease who's had at least 2 prior chemos, one in the metastatic setting. They had to receive taxane. They received TOC-TMT, which is given every 2 weeks. This is, I think, why people got the every 2-week idea, because they saw it with SOC-TMT on a trial and said, oh, I'm going to try it with sacituzumab govitecan. So they did the SOC-TMT, typical physician choice of chemotherapy is second, third line beyond, and the primary endpoint was PFS. Again, very, very significant benefit here. As you can see, 6.7 months versus 2.5. Similar when you really kind of do the overlapping confidence intervals to what we saw with ASCENT, maybe a little bit better. The hazard ratio is 0.32. You really can't do cross-trial comparisons, as you know, but the p-value was statistically significant here with the Optitop. So looking ahead, there are other trials that are going on right now. There's Tropion Breast 05, which basically is patients getting Dato with durvalumab versus Dato and standard Dato, or standard physician choice of chemotherapy. And so this is really testing in the PD-1/L1 positives, very similar to ASCENT 04. It's using durvalumab because I think, as we all know, Pembro has gone biosimilar, so there's less interest in developing it from the people that have the money to develop it. So that's kind of the where we're going, at least with Dato.
Quick question before we keep going here. Actually, this is from Brad Monk. A question we hear a lot about TROP2 ADCs, correlation with TROP2 expression. What do we know about that, Adam? You know, there was, I think, one study in non-small cell lung where they did this membrane cytoplasmic thing.
Yeah.
Any hope for that?
No, there is a trend, but it's not statistically significant is the best way to describe it. And I think most of us do not do TROP2 testing because of it.
Here's a good one from the audience as well, Kevin. Any data, or how would you approach a patient who's a BRCA mutant presenting with de novo disease?
So if this patient, in the 40% of patients, PD-L1 positive tumors, I would still lean towards ADC plus Pembro only because of this potential for having durability of a response. I do think that if it's PD-L1 negative, for some patients, doing PARP inhibitors is absolutely reasonable. I think one of the things that we see with PARP inhibition, I'll talk a little bit about this, is just the length of the response. You can get some really nice responses, but that is one of the issues with the PARP inhibitors.
All right, let's keep going.
So again, keeping in that ICI kind of theme with ADCs, there's some very interesting data from the phase 1 trials, phase 1/2 trials of Data-Durva, where it shows a very, very high response rate where about 80-90% of the patients are actually PD-1/L1 negative with a CPS less than 10. You can see the response rate here is almost 80% with a PFS of 14 months, a huge duration of response. And so they have this diamond randomized phase 2, which is kind of interesting, where patients with metastatic triple-negative breast cancer, no prior chemo, within 6 months in the first line, are being randomized to Dato or Dato-Durva. It's kind of a very interesting trial. I'm really interesting to see what happens. Because we know this, we know from Keynote 522 that it works, PD-1/L1 inhibitors work regardless of PD-1/L1 status. So this is kind of testing it now in that first-line setting.
I mean, CPS at 10, though, you calling that low, PD-1 low, under 10?
Yeah, I would call it low. But, again, there's low, which is 0, and there's low, which is 5.
There's low. I mean, we just talked about 1 in the gastroesophageal cancers and PD-1 of 1, and they use IOs. So
right, and so we may be starting to do that in breast. That's a good point, Neil. Yeah. Anyway, so keeping going with this. So again, we have a bunch of other trials that are going on. Again, we have SASIO-IO. These are now, again, metastatic triple-negative breast cancer, randomized to sacituzumab and Pembro, or sacituzumab alone. Again, going with this ICI checkpoint inhibitor in the PD-1/L1, at least we'll use it in quotes now, negative. Trofuse is SOC-TMT with or without Pembro, again in the PD-1/L1 low or negative groups. So again, I think the idea here is to see if there's any benefit, like there is in Keynote 522, to IO in this first-line setting. There probably are going to be patients who still retain responsiveness, although most of the patients, I believe, in these trials have not had prior Pembro. So it's going to be really interesting to see kind of where this lands. Will we have a group of people who will be like neoadjuvant therapy that will respond to the IO with the ADC in first line?
Just to look at that, though, it's interesting, Kevin, in terms of, we talked about HER2 low. What about ER low? I see ER less than 5%, less than for ER and PR. What do you do with ER low? When does it become triple negative in your mind, Kevin?
Yeah, I mean, this is one of the great debates. Generally, it used to be in clinical trial design that it really needed to be strict, less than 1%. Now there's this allowance to have ER lows, which is really less than 10%, and these are patients that we think don't have terribly estrogen-driven tumors.
So I'm curious, Adam, how you approach it, and pretty big difference in how you approach them, whether you call it ER positive or not.
So I think most of us use the rule of thumb less than 10, and we try to do it. We try to give, at least in our practice, we try to give IO. And for Keynote 522 is a perfect example, not in the metastatic setting. I think that, what we're really trying to do here is understand the biology of the tumor. Is it a basal tumor, or is it really a luminal tumor? And even luminal tumors actually have IO responsiveness, believe it or not. But I just wish we were a little bit more precise than, in maybe using molecular ways of kind of figuring out what the true subtype is, as opposed to kind of like guessing based on their ER. I wish we had, and we have tests that do this. It's just a question of whether we're going to use them in the metastatic setting or not.
All right, let's keep on.
Okay. So again, the last kind of part of this, and I think this becomes really important, and not only for breast, but for just about every tumor where ADCs are being used, is really what drives resistance to these compounds. And it's really difficult to tease this out because, again, you've got three separate things you're dealing with: the antibody, the linker, and the payload. And what's the resistance to? We automatically assume it's resistance to the payload, right? You're resistant to the underlying topo-1 agent. But there's a lot of ways that people have found that. This is data from MGH, and that's really interesting data. This is from neoadjuvant disease, as well as metastatic disease, and patients who are on TROP2, they actually sequence the metastases or in various areas after being on it for a while and gaining resistance to it. And you can see, there are TOP2 mutations that occur, there are P53 mutations, but they all kind of come off this trunk. And there are a variety of different mechanisms that you see here. One, actually, that's not shown here is that there's actually recirculation of the antibody. And at least in cell lines, you can show through some very sophisticated molecular biology that actually some resistance can be from recirculation of the antibody. So, there's a lot of things going on here. These are very complicated molecules. But at least as a rule of thumb, I think a lot of us believe it's resistance to the payload is probably the dominant one. I'm curious to hear what Kevin has to say about this. But I think most of us, but there's mutations in TROP2 that occur. There's a lot of different mechanisms that are here. And again, this just shows you the various mechanisms. There's this TROP2 recirculation, TROP2 binding, TROP2 deletion. There's a lot of, recirculation of the antibody. There's a lot of ways that you can get resistance to this besides the payload. Now, we know this because we've obviously, in breast cancer, we try to use one thing after the other, especially in a patient with a very good performance status that you really have not a lot of other good options. And so this is actually ADC after ADC. So both in the setting that we're really not talking about today, which is the HER2 positive, the hormone receptor positive setting, and in the triple negative setting, as you can see from here, this is retrospective data. There have been multiple retrospective analyses that have been done. This is the one small one. There's a broad variety. There's a much larger one done by the Dana-Farber group, and within the last year or two has been published, showing that you just don't have a lot of response from one ADC after the other, especially when you have the same class of topo-1 payload. You can see, SG after TDXD doesn't really work that well. TDXD after SG also doesn't work that well. But there's still about 10, 20% of patients who do have a response. And I'm really curious as to who they are. I think we're all really very, very curious to who these people are because maybe we can come with biomarkers that'll help us figure this out at some point. But anyway, that's kind of where we are. And this is the larger data, actually, that I had hinted at from Paula Tarantino and the group at Dana-Farber. Again, showing basically the same thing, that there's just not, this is from the Flatiron Registry, there's most therapies post-DXD, and DXD in particular, but it also is for SG as well. It just is not a lot of response to therapies afterwards. And I think that's the really big mystery in the breast cancer business is what do you do in the metastatic setting after you progress on one of these antibody-drug conjugates? I don't think we have a good answer for it. Most of our data, most of our clinical trials are non-post-ADC. Thankfully, the new designs all require post-ADC. The vast majority of the earlier phase studies are going to require post-ADC here. And then finally, I think there's a bunch of sequential ADC trials that are out here. TRADE-DX is one that we're all participating in, I think, in the U.S. It's a smaller study, randomized phase 2, where you get either T-DXd or Dato-DXd, and then the opposite at progression. And there's a lot of biomarkers from a group called TBCRC. There's a lot of biomarker data involved with that. But there's a bunch of other ones, Encore, as you can see here, series, really looking kind of at the question of what do you do post-ADC, and does one ADC work after the other? And hopefully, we'll have some data in the next year or two to kind of help us figure out, and hopefully from TRADE-DX, maybe have biomarkers to tell us who's going to respond to one ADC after the other. And I suspect most of us still will do one ADC after the other. I do it in my practice. I'm curious what Kevin and you guys do. But I think we're still going to do it because we have nothing else to do. That's really the problem here. So again, these are some of the other selected trials. These are, again, bringing these into earlier stages. It's kind of the theme here. Really some of the ADAPT studies that are being done now are bringing it into selected stage 1 and stage 2 triple-negative breast cancer as adjuvant therapy or neoadjuvant therapy with ADAPT. One of the other ADAPT trials, Tropion-Breast04, is really an interesting trial, actually, because it actually is using durvalumab, chemo, and olaparib as a control arm. And I'm curious whether we can give olaparib with Dato-DXd, but that's another question. But again, it's trying to bring these drugs into the earlier setting. And again, some of these other trials, Trafuse, Ascento-5, Trafuse-12, again, are both either is adjuvant or post-neoadjuvant therapy. I think that's really where I think the first data from these trials is going to come. It's really going to be in that post-neoadjuvant setting from Ascento-5 and trials like it. We're going to see the data whether an ADC is better than the standard of care that we've been using, which generally is CAPE or maybe olaparib. Olaparib, I don't think is allowed in Ascento-5. But the bottom line is that what do you do for residual disease? And I think we're going to see if there's going to be that benefit beyond. We don't know, and I think it's going to be really interesting to kind of see the data when it comes out. So this is kind of where we are right now. I think this is kind of end. The NCCN guidelines clearly allow, at least for CPS greater than 10, the standard first line is sacituzumab and pembro is category 1. Sacituzumab and Dato are really both preferred for reasons that I guess I don't know why, but sacituzumab is category 1 for the ER negative, the CPS less than 10 patients. So again, I think that we have two good drugs. There was a really, really good discussion of this at ESMO when all this data came out that basically said we're very fortunate in the triple negative space in metastatic disease to have two drugs that really work very, very well. And I think that the differences kind of, are stylistic, I think, between the two drugs. I think I could use them interchangeably in my practice. I can't, unfortunately, use Dato with IO yet because it's not FDA approved and probably won't get paid for. So, but again, I think that that's where we're going here.
So we're going to move on and have Kevin present some more data. Before he does, though, just curious, Adam, where T-DXd fits in your sequence in the metastatic setting in the HER2-low patient.
So if you're triple negative, I think there's not a lot of data for DXd, and so for T-DXd. And so what I generally do is I use it for the hormone receptor positive HER2-low. That's my first choice. For triple negative, I will use a TROP2 antibody.
And then what about after that?
That's a great question, and I think that it's one that doesn't have an answer. We don't know what to do. I will use it, and I have had responses, again, probably 20, 30% of the patients will have some response that's reasonably durable, maybe 3 to 6 months, but I'm seeing the same thing pretty much that we're seeing from the real-world data. But I will use it because, again, what else? The issue is, what else do we have? Single-agent chemos, clinical trials. I mean, we don't have a lot for people when they progress on SG.
So, Vic, any questions before we move on?
Yeah, so essentially I think we kind of touched SG versus Dato. I think is right now choice of the patient. I've been presenting it. Some of my patients have chosen to do a Q3-week regimen. They don't want to come in every week. They don't want growth factors, all that stuff. So other than that, I don't think there's any other thing to differentiate the two from what I'm hearing.
No, I think they really are interchangeable in many ways. It's just a question, again, do you want to come in every 2? Are you more familiar with one drug than the other? Are you more worried about ILD? There's a lot of things that go into this. It's a lot of clinical judgment of both the physician and the patient desires that I think goes into this sort of question.
Either of these drugs have a better penetration in leptomeningeal disease, do we know?
That's a good question.
Yeah, I don't know that we know. There was a prospective SWOG study that was actually looking to really look at SG, but it had low accrual and won't be completed. And so I don't know that we know that we think, because like TDXD has very good penetration, that the same may hold true for Dato-DXD. And the only other thing that I will say, and this is the challenge of doing cross-trial comparisons, but the response rate was just a little bit higher with Dato in the front line compared to what we've seen with SG, and it may be different patient populations, et cetera, et cetera. But if I have a patient I really need a big response, that's one other thing that may push me over to Dato.
Yeah.
All right, let's keep moving here, Kevin, and we'll get into some other issues, including Keynote 522.
Yes. These are my disclosures. So Keynote 522, study that I think most in this room are quite familiar with, which looks at the role of giving pembrolizumab in the context of early stage or stage 2, 3 triple-negative breast cancer, paclitaxel, followed by an anthracycline and cyclophosphamide, where patients got pembrolizumab every 3 weeks versus placebo, and then went on to surgery. And everybody, regardless of what their pathologic response was, then completed out a year of pembrolizumab or placebo. These are the most up-to-date overall survival data that we see with pembrolizumab. You can see that this is the 5-year rate is a difference of about 5% or so. So this drug not only improves event-free survival, but also overall survival. And as Neil mentioned, at ASCO this year, Peter Schmidt will present additional updates of survival from this trial. There have been some analyses that have gone back and looked at some biomarkers, one of which was PD-L1. And while the magnitude of benefit seemed to be higher in those who had PD-L1 negative tumors, and again, this was done on the primary tissue, the benefit was really noted regardless of PD-L1 status, and the vast majority of patients had PD-L1 positive tumors. And so as opposed to what we do in the metastatic setting, in the early stage setting, we're not looking at PD-L1 status to determine who benefits from giving this regimen. Pivoting to metastatic disease, Adam had already mentioned ASCENT-04, so I'm not going to dive into these data in any particular depth, but I will say that also at ASCO this year, in a couple of months, we'll see updated data from ASCENT-04, similar to ASCENT-03, which Adam had mentioned, where the vast majority of patients had gone on to get second-line sacituzumab. Its crossover was included in ASCENT-03. The same is true for ASCENT-04. And we'll see PFS2 data for both ASCENT-03 and ASCENT-04 at ASCO. So we've had a little bit of a discussion about PARP inhibition in terms of the early stage setting. The Olympia study, which included patients with triple negative as well as high risk hormone receptor positive HER2 negative disease, were included. For triple negative disease, if patients received neoadjuvant therapy and did not have a pathologic complete response, they were eligible. These are for patients who have germline BRCA mutant tumors, right? So this did not include, for instance, PALB2 hereditary tumors. And patients were randomly assigned to receive olaparib twice a day versus placebo twice a day for a year. And we've seen with updated data that there's an improvement not only in invasive disease-free survival, but also overall survival. And this is really standard of care for our patients with triple-negative disease who have residual disease, giving olaparib to our patients. In terms of the metastatic setting, this question came up already a bit, just in terms of the utilization of PARP inhibition. We have 2 PARP inhibitors that are approved in germline BRCA metastatic disease, olaparib based upon the Olympiad study, and then tilazoparib based upon the EMBRCA study. One, we saw a statistically significant improvement in progression-free survival as well as quality of life measures. I will say if you look at the overall population, there's not an improvement in overall survival with PARP inhibitors in BRCA germline mutant patients. However, if you look in Olympiad and you look at that first-line population, one can see that there was this improvement in overall survival in this population. So just to reiterate one of the points that I had made, if you have a patient who has a PD-L1 positive tumor, I would still give an ADC, in this case SG plus pembrolizumab. It is one thing one could consider in PD-L1 negative disease, but again, just to highlight, the duration of response can be a little bit more limited with PARP inhibition compared to what we see with, for instance, ADCs. So this was a study Adam had already mentioned, TBCRC. This came out of this group. This was a trial that had been presented with some updates that looked at patients who either had germline mutations or somatic mutations, but not just BRCA, but looking at other alterations in homologous repair deficiency like PALB2 and ATM and CHEK2, where patients in the study got olaparib, and this primary endpoint was response. And so what one can see is in yellowish, if you look at germline, this is germline mutations, one can see that not all of the different alterations are the same. Those who have germline PALB2 mutations can have responses. And this is different than what we see, for instance, with ATM or CHEK2, where it does look like, as opposed to them, those who have germline PALB2 mutations can have responses. So there were also data that were looking at somatic mutations. What you're seeing in this waterfall plot is across the spectrum of different alterations, where those that are light blue or dark blue are those who have somatic BRCA mutations, and then you can also see that there were a small number of patients who had PALB2 somatic mutations, but really just to emphasize that there were some nice responses, including as well as clinical benefit rate, that was seen for patients who had somatic BRCA mutations. And this is looking in that in a little bit more detail. That's breaking out BRCA1 and BRCA2. BRCA2 in this plot is having the darker hue to it, but one can see that, again, this is somatic, it's not germline, this is somatic, that you can have some responses both with somatic BRCA1 and BRCA2 where that response rate was nearly a third. And this is just a slide that is summarizing on the left what you're seeing in terms of the response rate for germline PALB2, and then also what you're seeing with the response rate in somatic BRCA1. And so, I mean, the number of patients in this study was limited, and we're awaiting results. For instance, there was a study that was completed from our Mass General colleagues with talazoparib in this population, and we'll see what those data show as well.
Adam, real quickly to you, choice of PARP in the metastatic setting, also in the localized setting, neoadjuvant or post-neoadjuvant or adjuvant. What about somatic BRCA? What about PALB2?
Those are a lot of questions, so I'll take them quickly. All right. The first one, it doesn't really matter which one you use. I've used both. I mean, the biggest issue is that olaparib is, I think, 4 pills a day versus talazoparib, which is 1 pill a day. So I've just had people who have terrible anemia or whatever, don't like taking 4 pills, I'll switch, and sometimes the anemia, which is probably the biggest side effect with this drug, tends to get better. I'm a little disappointed. I participated, all those ATM patients were actually mine, in TBCRC 48. We're kind of disappointed that the only mutations that seem to work in breast and you get response in the metastatic setting, whether they're somatic or not, tend to be BRCA1 and PALB2. It's unfortunate. We really wanted to be like, I know Brad Monk's here, we really wanted to be like the ovarian guys where we saw a response, just from the homologous recombination deficiency, but we don't. For some reason in breast, we're just not getting the same data that we got in ovarian. So I do use somatic BRCA. That answer that question. I think I got that question. Which one? Adjuvant, I will use PARP. Clearly, if you have residual disease, where you use PARP is anybody triple negative with residual disease after neoadjuvant therapy should get a PARP. ER positive, it's adjuvant for T2, N2 and above. That's N2 and above, I would do it. T3, N1 and above, I would do it. Residual disease after neoadjuvant chemotherapy, I would do it for hormone receptor positive. BRCA positive. I think that answered all your questions?
Yep.
Yeah, okay.
So, Deb Armstrong this morning said, hey, they taught you guys all about PARP inhibitors. You're always teaching everybody else, but in terms of
correct.
PARP, they got it first. All right, let's keep going, Kevin.
All right. So ADCs, one of the points I just wanted to emphasize, and Adam kind of had alluded to this, but for patients who have hormone receptor positive, traditionally HER2 negative disease, there's a higher rate of HER2 low, that's about 2/3. You can see the bottom of the slide, HER2 ultra low is about 25%, but that's different than what we've historically thought about for metastatic triple negative breast cancer, where it's only about 1/3 have HER2 low disease. We've touched upon very briefly TDXD. So the data that was looking at patients with HER2 low disease, these were data that were presented by Shinu Modi that you'll hear from very soon. This included patients both with hormone receptor positive and in a smaller population of patients who had hormone receptor negative disease. These were patients who had 1 to 2 prior lines of chemotherapy in the metastatic setting, 2-to-1 randomization of TDXD, which is given once every 3 weeks, compared to physician choice chemotherapies that you can see that are listed here, with the primary endpoint being progression-free survival. And we saw overall in the overall population, again, the majority of the patients in the study had hormone receptor positive disease, an improvement in PFS and overall survival. And these are the data for patients with hormone receptor negative disease. It's a small population of patients, right? It's about 60 patients, which goes to the point that Adam was making. If we think about our patients with hormone receptor negative disease, we just have more robust data with our TROP2 ADCs compared to something like TDXD. But one can see that there's an improvement in both PFS and overall survival with a hazard ratio that's a little less than 0.5. These are the longer-term data in patients with hormone receptor negative disease. Again, this is all HER2 low, and you can see that there remains a benefit in this smaller population of patients. As Adam had already alluded to, the first ADC tends to work better than the second ADC. And the other thing that has come out of these real-world studies is this question of, okay, should you directly sequence? Should you give some sort of treatment in between? Sometimes we call that the sandwich approach, where you give an ADC and then maybe you'll give chemo and then give an ADC. Ultimately, didn't really seem to matter. The first ADC tends to be better than the second ADC. This goes to one of the questions that had come up about, does TROP2 expression matter? One of the caveats that I will say is across all of the different randomized trials with the different ADCs that are available, there are actually different assays that are being evaluated, which is also one of the issues, is that the biomarker development is really not so consistent. Another thing that I wanted to mention is that the majority of patients have higher expression of TROP2. And so you might see on the table in the curve, those who had low TROP2 expression, there is a suggestion that maybe they're not having the same degree of clinical benefit, but it's a small population. And right now, clinically, we're not utilizing this as an integral marker when we're determining who may or may not receive an ADC. And again, this question of whether we're really looking at expression correctly, in breast, we've been debating for HER2 how we should be evaluating this, and the same holds true for other markers, including TROP2. And then I just wanted to leave you with where I think the future is heading. I would like for you to keep your eyes on the VEGF PD-1 or PD-L1 bispecifics. At ASCO this year, our thoracic colleagues are going to present some phase 3 data. In breast, we have a lot of interest in these agents as well. There seems to be benefit, at least if you look at the earlier phase studies, regardless of VEGF expression or regardless of PD-L1 expression, and these drugs have moved quickly into randomized phase 3 trials in metastatic disease.
So we're about finished here, but just one real quick case for you, Adam, real fast. Patient was on Keynote 522. The last cycle, her tumor increased in size. Surgical pathology was a 6-centimeter tumor with negative lymph nodes. What would you do, assuming she actually the tumor is getting bigger?
So the tumor's still intact.
Yeah. Mm-hmm.
It's a great question. I mean, I would think about an ADC if I could get it, honestly. The issue, though, is she doesn't really qualify because she doesn't have unresectable disease. You'd have to say she's unresectable. Maybe you kind of fudge it a little bit and make her unresectable and give her an ADC. That's how I would do it.
All right, we're going to move on to HER2 positive. Thank you so much.
Thank you.